So I've been tasked with embedded inequality in the treatment of lower limb ulcers. I sort of sat a bit in the back corner this morning, changing the talk a little bit, and then sort of listening a lot about the patient-centered aspect of the discussion points. I sort of wanted to add a few things about that in this talk as well. So it's sort of split in those two categories, really. And what I hope to do, essentially, this morning is just present some new data on the topic. So we've got good data already. We've got systematic reviews and meta-analysis looking at global data around the epidemiology of venous disease, its progression, and its likelihood of getting to ulceration and what it takes to actually heal an ulcer, or factors that affect ulcer resistance in the community, and so on. So this project, or this data, has largely been from the CPRD. And CPRD is the Clinical Practice Research Data Link. And it's essentially a data that supports both prospective and retrospective studies. And it does this by actually taking GP level data and then anonymizing it and actually communicating it to secondary care, in the sense that you're able to get data from other health-related sort of agencies. So be it hospital admissions, outpatient clinics, emergency admissions, so both elective data and so on, procedures, cancer registries, etc. And what it does is it anonymizes this data, and then you're able to, as a health researcher, you're able to actually take that data and then apply it into different questions. So you want to look at the completeness based on the questions that you're asking, as well as the population that you're looking at. But you get information on geographic locations, and you're able to see how different initiatives affect disease progression and so on in different groups of patients. So the electronic health record story is an interesting one. 1995 was the start of it. We've got a publication here, 2,000 people in the registry that have electronic health records, and 16 GP practices that took part. And this is vastly different in 2022. We now have up to 27 million people in the electronic health record system, and on nearly 1,500 GPs that participate. And so what does this mean for leg ulcers? What can we do with this data, and what questions can we get answers to from it? So the aim very much of what sort of the project that I had undertaken was to evaluate the electronic health record system, to look at trends in population burden of venous disease, in the natural history of venous disease and associated factors, and the clinical management of venous disease. But most importantly as well, is we wanted to see how the hospital initiatives or the national initiatives have impacted epidemiology and the management of chronic venous disease care. And we heard a little bit, again, from Prof. Whiteley, what those initiatives are and how NICE plays a role in that. And I'll touch on that as well. So this study was a retrospective observational study. It was something called the nested case control study. And what this is it allows you to take a case control study embedded from a cohort study. And the cohort aspect of this study is pretty much the electronic health records. And the case control aspect is matching both age and sex, 2-to-1 control, so people that don't have the disease, to ones that had the disease in the cohort study. And that's sort of how you're able to do a more focused case control from this data. And the data's been over a 10-year period, 2008 to 2018. The sources, I touched on the CPRD. The other areas that we looked at was the hospital episode statistics. So this is curated data that looks at admissions, at outpatient appointments, and then historical accident emergency admissions, or sort of episodes of care for England. And then as well as the Office of National Statistics, it looks at population data, at national and more regional data. So we will pull that out from primary care as well as secondary care. So these were based on diagnostic codes for chronic venous disease. They were adult patients, and it was research quality data. What that means is that you're limited to ensuring that the data fields are completely filled out. So, if you've got 120, so you've got 27 million people, how many are completely filled out for the aspects of care that you're interested in? So it needs to be filled out that way. And the statistical analysis was done as described. So what do we get from the 27 million? Well, we had between sort of 7 and 8 million people that had research level data that was collected on them. And what we saw was minimal changes in the incidence of varicose veins and only a mild reduction in venous leg ulcer incidence. So what you have on the figure on the right is the incidence per 100,000 people. So in 2008, for varicose veins, there were 299 episodes or incidents per 100,000, and that's only decreased to 285. And for venous leg ulcers, again, only mild reduction, 106 to 90 per 100,000, and this is despite advances in intervention as well as sort of pathways, treatment pathways, etc. So minimal improvements. And what do we know about the natural history? Well, from this study, we were actually able to look at mortality. So these were patients that were age-matched, sex-matched, and matched for all other comorbidities. And it showed that actually patients with venous leg ulcers have an increased risk of mortality compared to those without in the same sort of health-related categories, on a hazard ratio of 1.39. So that's quite significant. So venous leg ulcers predispose you to increased mortality, and that data has never been shown before. Progression is another one. We sort of heard from Prof. Whiteley about the progression of disease. We know very little about the factors that actually cause progression of disease from, let's say, C2 to C6, or even if you increase one CEAP category classification. We've seen global data suggest that progression happens in about a third of patients. Now, from the cohort of data that we had, which was the 280,000 from that group of 7 to 8 million with research quality data, we saw 79% had no significant disease progression, which was interesting. 13% had significant disease progression, and that's classified as a change in CEAP classification of 1. And 8% progressed to ulceration. Now, the limitations in this data is that it relies on actually having 2 episodes that are categorized in the database. So they need to actually see a GP, see a specialist, and actually have that information coded on 2 separate occasions. So they might have progressed, or they might have progressed either one CEAP classification or gone into ulceration, but if they never then seeked another episode of care, then that wouldn't be picked up in the database. So if anything, it's underrepresentative of what we may be seeing. But from that data, we're able to do some investigation to see what variables actually reduce the likelihood of progression or what increased it. So the green table represents factors that actually reduce the likelihood of progression. So these are things like being female, having previous pregnancies, antidepressants, hormonal therapies, and lipid-lowering therapies. So there's some confoundings in there. In other words, there's certain groups of patients that are more likely on certain types of medications, cardiovascular disease, and so on. The factors that affect or that increase your risk of actually progressing to ulceration is being white, having a previous DVT or PE, in this case DVT, and then calcium channel blockers and cardiovascular disease. Those are, again, overlapping factors. People with cardiovascular disease have calcium channel blockers a lot of the time, but having cardiovascular disease increases your likelihood of progressing to an ulcer. And the ulcer recurrence rate in our sort of study was roughly 30%, which is very high. So what are the factors that are associated with patients having C2 disease or C6, so symptomatic varicose veins versus active ulceration? Now, when I looked at this and I sort of put the slide together, the thing that really stood out for me is that this looks like 2 completely separate diseases. The predisposing risk factors are completely different for both categories, which I think is very, very interesting. So for C2, you're more likely to be female, Asian ethnicity, having previous pregnancies, being on hormone therapy. Being C6, you're more likely to be male, white. In terms of the CVD here means, rather than chronic venous disease, cardiovascular comorbidities, and being more frail. Now, with that information, how does that compare to what we know about the global factors that are associated with chronic venous disease? Well, this list looks rather similar. So this data comes from the above paper, and it's a meta-analysis. So it's not able to look at as granular in terms of the different categories of C, but for people that have chronic venous disease, you're more likely to be female, you're more likely to be older, obese, be in positions of prolonged standing, so jobs like being a hairdresser, working security, being white, having a family history of it predisposes you to it, more children, increased likelihood of it, and having a previous DVT. So there's a lot of overlapping factors there. Now, this I found quite interesting, and it parallels what Prof. Whiteley had said. So this is essentially a graph. We've got the x-axis is looking at years over a 10-year period from 2008, and the y-axis is the proportion, and they're clearly diverging. And what this graph is showing is the blue line represents the time from decision to admit from a procedure. So they've seen a GP, they've been sent to a specialist like a vascular surgeon. The vascular surgeon's decided this patient needs an intervention. What's the time it takes from that specialist decision to actually getting the intervention you need? The green represents hospitalizations which are elective. So you plan procedures versus patients coming in with infections or increasing pain that they can't manage at home and so on, being emergency. And the red represents the hospitalizations that are associated with the elective procedure. So in other words, it's a surrogate marker of how many procedures are being done. So in 2008, you're looking at 63 weeks from the time it takes to being seen by a specialist to getting the intervention. And the number of procedures that were done per 100,000 was roughly 71. Now, in 2018, 10 years later, the time it takes to get your procedure has increased, and the number of procedures that we do have decreased. And the really shocking thing is that in 2015 is when the nice sort of guidelines came out, and the recommendations to follow those nice guidance had come out. So we're in a divergent situation from when the data started being collected, but actually having nice guidance hasn't improved the outlook at all. So how does this translate geographically, and links back to the title of my talk? Well, Dan Carradise, who's based in Hull, did a beautiful study basically looking exactly at that, looking at how the NICE recommendations have been applied across the country, across England, and seeing how commission restrictions as well as inconsistent commissioning has affected care. So the green areas are areas commissioned for symptomatic varicose veins, so symptomatic C2 and above. And the red areas represent areas which don't actually commission for C4 level disease or even ulceration. So if patients were identified with having skin changes or active ulcers, they would need to seek special measures to actually get funding to get the interventions they needed in these particular areas. So the same paper then, again, same map, different colors. The green areas represent areas in England which are compliant with CCG guidance, with NICE guidance, and the red areas are non-compliant. And the gray area, for which there aren't many, is no current policy. But what it's shown is that the majority of CCGs in England have commissioning policies that contradict NICE guidelines. And this is essentially showing that rationing strategies are created unwanted geographical variations, which I'll highlight in varicose vein treatment. And this has a knock-on effect as well to what Prof. Whiteley said about training and trainees. I mean, I'm a registrar as well, so I'm in training as well. And you go to conferences, you see how different trainees have responded to, in particular, vascular surgery trainees have responded to how well they feel or how proficient they feel at the end of their training in treating these patients. And even at the senior level, you see about a third of people that are nearing their CCT, their completion of training, feel comfortable. And that largely has to do with a lack of opportunities. If the commissioning is not happening, you're not seeing the patients, you're not doing the procedures. So it has that knock-on effect. Now, this was an updated paper from 2023, also done by Dan's group, which is looking at new evidence-based intervention groups, which again were meant to improve the likelihood of getting nice guidance adopted by CCGs. And green is showing that they're compliant, sort of amber and red are what you expect. And again, since these evidence-based intervention groups have been introduced, compliance with NICE guidance has reduced from 34% to 29% in that same time. And so roughly 75% of CCGs are providing less than the recommended intervention rate that's offered by NICE. So I'll take two examples from our own data, going back to the original graph. You've got the southwest of England, which is amber and red, and you've got London, which is primarily green, being compliant. So how does this affect things like treatments and ulcerations and so on? Well, we've got the incidence of varicose veins being relatively similar in both those groups, which you'd expect because the data is fairly national. The referral rates in the southwest of England are lower compared to London, referral meaning to specialist care. The elective admissions are fewer. The number of procedures that you do, consequently, are less. And the procedure waiting times are increased for the southwest of England. And this, unsurprisingly, shows that the venous leg ulcers in these two areas are significantly different. 175 per 100,000 in the southwest of England and 78 per 100,000 in London. So these commissioning policies have a knock-on effect in real terms of how well patients are doing. And I think that's quite stark. Some of you may be familiar with LUPA, and this was sort of another area, I think, that's showing an area of sort of excellence in terms of treating patients with this, with venous disease. So these were the real difficult group that Prof. Whiteley mentioned. So the ones looking at the idea that despite recurrence and multiple treatments, you're unable to actually get ulcer healing. Now, prior to about 2015 or maybe even 2012, the idea of iliofemoral disease and iliofemoral obstruction wasn't something that was really looked at. And routinely, if you had a duplex, people weren't checking the iliofemoral system to see if there was any scarring or such that could explain this. So they'd get a duplex of their leg. If there was superficial disease, they'd have it treated. It could be treated by sort of endovenous techniques. It could be foam. But then they'd go out in the community. If they were symptomatic, some of them would present, some might not. They may be lost to follow-up. They may be in the community developing an ulcer, and it's difficult to find them. Now, what this hypothesized was that if you've got recurrence of your ulcers, if you've got recurrent disease, it could be that something higher up, such as your outflow, is being affected, and therefore, despite you treating the superficial system, it keeps coming back because the pressures are quite high. So it essentially aimed to take 110 patients with recurrent ulcerations or large ulcers that weren't healing, and then match them to patients that were existing in hospitals or community centers that didn't have proximal obstruction. And they scanned the 110 and actually found that a third of them had outflow obstruction that was amenable to stenting. And that was compared to only 2% in the control groups, the ones that were in hospital that were getting the more up-to-date imaging that we know didn't have outflow obstruction. And the stark result was that at 12 months, 80% of those that had outflow obstruction that ended up getting treated healed the ulcers within that year, compared to only 20% in the control group. And so it's another thing about, well, actually we need to educate and we need to find the patients that didn't have the appropriate treatment so that we can get them back into the system, get them the investigation, get them the treatment they need. So venous care is evolving as well. So from the data, what does the management of chronic venous disease look like in the cohort? So the numbers on the left again, so this is now just the northwest of London, which we had the most robust data for. Roughly a quarter of patients were getting compression, 10% had a duplex ultrasound in the community. A third of patients were referred to see a specialist in clinic. Roughly 15% underwent surgical or endovenous intervention, with half of those being radiofrequency ablation. Those numbers are very low, very, very low. And then you look at the overall healthcare costs that are associated with this. This again has to do with northwest of England in particular. But if you look at the direct chronic venous disease care, so the additional amounts that are associated with primary care, the huge additional amount that's associated with community care, the indirect costs, sort of non-elective admissions into hospital, A&E admissions, procedures and outpatient appointments, so additional amount that's required. It's a stark amount of money in unplanned care. So that was sort of my kind of attempt to try to show some new data in this area based on our own national hospital statistics. The words patient-centered care have been sort of mentioned quite a lot to me since I've been here, as well as being, I think, a lot more in sort of on the clinical and healthcare related sides. And that's not only because it's far, far better for patients, but it also has a knock-on effect in terms of the quality of care that you can give patients. And I just want to show you or share with you my experience with it. So I was involved in about a 1.5 year long project with the International Consortium of Health Outcomes Measurement, which was specifically aimed at developing patient-centered outcomes for VT, so venous thromboembolism, and then ways of implementing it and what we've learned from that whole experience. And my sort of proposition really is that we need to do the same thing for venous leg ulcers. And we need to do that for multiple reasons, and I'll go into that in a bit more detail. But what are patient-centered outcomes? So they're outcomes that we need to measure not only the process of measurements, but as well as its recording. And we need to do this to ensure we've got standardization across the board when we talk about treatment, right? And, so what are the selected outcomes that we need to include? Well, they need to represent the end results of care. They need to be important to the persons with VTE. And I think that's the most important thing, is we need to constantly remind ourselves what are the things that matter most to patients. They need to be feasible to capture. They need to be modifiable. So the modifiable aspect is quite interesting, because when you start measuring the factors that matter most to patients, you find out that they change, because when they get addressed, they stop mattering. And new things matter. And so this needs to be very much a kind of a quality improvement type process where we're constantly updating it. And they need to be valid across cultures internationally. We can't do this in a silo, make these decisions with only a few patients. It needs to be an international project. Every continent needs to be involved. Patients from every continent need to be involved, and we need to get that information. So this would be a sort of a geographical representation of the working group that was involved in VTE. It was 35 countries, 15 countries, 35 clinicians, and the same number of patients that were represented in each one of the areas. And these were the core outcomes that were decided on for VTE. And the way we got to that point is that different disease states have identified outcomes that mattered across the board. Those were included in the numbers. You also go through literature. So what are the sort of clinical studies that exist in the system? What outcomes are they measuring? And you populate a list of those. And in addition, you have a lot of focus groups, and you get patients to tell you what matters most to them. And you add that all into a very, very long list. And you start doing something called a Delphi consensus. So you get patients involved, experts in the field involved, and you whittle that down to something that's manageable, that's very reflective of what matters to patients. So they were grouped into 4 domains. So patient-reported outcomes, long-term consequences of disease, complications, and then treatment-related complications. And what we learned from that, what was quite interesting, was, well, if you've identified a series of patient-reported outcomes, the tools you need to use to measure these outcomes end up being quite varied, because there is no single tool that exists that addresses what matters most to patients. So it's quite a laborious type of process. So you need to have a validated outcome tool. It needs to be available in multiple languages. It needs to be cultural sensitive, etc. And what we ended up doing was use a cascade system. So if you've got an electronic health record system, you could have the series of questionnaires tabulated on the system, and depending on how you answer certain ones, it'll jump to the next. But it'll at least incorporate your functional limitations, pain, shortness of breath, satisfying with treatment, psychological well-being, and changes in life view. And depending on how people answer those defined core set, they may need to then go into the optional set. But this takes about 30 minutes, 35 minutes to answer. So it's quite labor intensive and is a limitation. There's also a series of clinical outcome measures that need to be reported. And those luckily can get pulled out from the hospital episode statistics. So they're there in your hospital records that you can pull out and you can start keeping records of. And the other thing that I think is hugely important, and it ties back into the geographical variations of things, is that you need these case mix variables, which ensure that you can risk adjust your model to be very representative of different geographical areas. So, different areas are funded differently. The level of comorbidity is different in these groups. The availability of care may be different. It needs to be representative so that one center doesn't look like they're just doing a fantastic job if others aren't at the same level par. So you need to take these different profiles into effect, and things like demographics, baseline health status, treatment-related factors, they play a role in it. And really, it's the whole idea is you need to be able to compare apples with apples. And when you do that, you get really interesting health outcome data and quality data. And in the US, for example, you're able to take different disease states. So there's about 45 which they've developed disease-specific sort of patient-centered outcomes for. And you're able to get really good information about what good quality intervention and good quality care looks like, and less than satisfactory. And how much the good quality care costs is not much different. And in a lot of times it's less expensive than poor quality because of the more planned aspect of the care that you can have. So we need to start sort of talking about that in that same language, I think, for venous leg ulcers, so that the studies we do are measuring the same things so they can be compared appropriately across different countries and so on. So for VT, what do those risk adjustment factors look like? Well, the demographic factors are sex, race, ethnicity, BMI, age, and level of education. And the clinical risk adjustment baseline factors are things like your comorbidities, whether you've been on anticoagulation, whether you've had a previous VT, and whether you underwent an intervention. And then you need to measure that. You need to measure the baseline evidence at index time, and then you need to do it at 3 months, at 6 months, at a year, looking at the outcome measures that include things like your quality of life and so on, and so that you get really good level data. So from all that, our electronic health records, they're useful in understanding venous epidemiology as well as the geographical variations. There's been some reduction in the incidence of venous leg ulcers, but this hasn't been significant considering that we've got a lot more advancements in access to patients and levels of treatment. Venous leg ulcers is associated with morbidity and frailty, and there is significant heterogeneity in the management of venous disease. And we just all need to do better, and we need to incentivize in any way we can to ensure that we improve that. And in terms of the patient-centered outcome, this is the publication that we published in Lancet Hematology on the development of these outcomes. And it goes through in a lot more detail than I said about what the process would be. But I think we need to do a similar process for venous leg ulcers, and I think that will make a big difference if everyone's looking at the same data, speaking the same language, and going after the same result. So thank you very much.